It's wonderful to welcome you this evening to tonight's launch of the UCL Commission on Culture and Health. My name's David Price, and I'm Vice Provost for Research at UCL, and it's my pleasure this evening to top and tail tonight's activities. So UCL is London's global university, a phrase originally coined, I think, to irritate the other universities in London. However, there is quite a lot of truth in that claim. We are an institution with outstanding excellence in research and teaching, from art to anesthesia, from the study of Zeus to the study of zoology. So the wonderful thing about UCL, therefore, is the potential that we have not only for disciplinary excellence, but also for the opportunity of being a centre of excellence in cross-disciplinarity based in disciplinary excellence. And one of the great pleasures that we've had over this period is to collaborate with my dear colleague Richard Horton here and the Lancet to ensure that we have a way of developing the final part of our strategy, that is impact. That we come together, we look at work, and then we generate an outcome and publish it, in this case, in the world-leading journal, The Lancet. This is our third collaboration on culture and health, and I hope in the future we will have many more.
Thanks very much, David, and welcome everybody. It's been 23 years since The Lancet used the word culture in its pages, and the man who led that first initiative, Roland Littlewood there, Roland, it's great to see you here, wonderful to see you, was the man who started The Lancet's intermittent love affair with medicine and culture. And if you go back and you look at the issue on April the 27th, 1991, Roland wrote the first article of that series, entitled From Disease to Illness and Back Again. What you read in this report, which is absolutely an academic paper in a journal, has profound implications for the way we deliver care in the health system in this country, but also in the way we respond to health crises in other countries around the world. It's my great pleasure to introduce to you David Napier, who has led this project, and David's going to take us through a presentation of the report with his colleagues. Please give a big, warm round of applause to Professor David Napier.
Now, in the end, it's impossible to name all of those who had a hand in assuring the culture and health came to fruition, as the individuals acknowledged in the document are only those who completed its actual writing and who responded formally to that writing with editorial advice. So I'd be grateful if you would join me in acknowledging the contribution of all those who've stood by us over the last 2 years.
We have social sciences, as David Price was mentioning, very rich. Scholarship at UCL. We have health services attached to UCL. But we have a gap there. One which is theoretical discursive, the other which is preoccupied with instruments and scores. And there is perhaps a language that is required to bridge the two, and that's how the cultural formulation developed. It's an intercultural dialogue which asks for a physician or a health professional to not just focus on the patient alone, but reflect on their own theories, their epistemologies, and their cultural identities.
The mental health of refugees is strongly associated with being able to speak the language of the host country. A study of refugees found a strong association between feeling autonomous and being able to speak English. Healing goes beyond healthcare. Becoming independent and socially involved is a very important part of it. That may take the form of playing football or growing vegetables or doing artwork. Or it may take the form of political and cultural activity, which unfortunately is often interpreted as rejecting the host culture.
I want to spend my 5 minutes talking to you about Scandinavian love, or the Swedish theory of love. If you have seen Scandinavian crime dramas on TV, you will probably think that this is going to be bleak and depressing. But fear not, Scandinavians actually have something to tell us about love, which, although as Scandinavian myself, I first really started to think about while working on this commission. When we have considered what the role of culture is in health and healthcare from multiple perspectives for this report, we have, maybe obviously, found that social equality is a central factor in people's sense of well-being. Building trust for healthy societies is a wholly cultural phenomenon. It is both very simple and immensely complicated, like love in Scandinavia, or elsewhere for that matter. Reading the final report, I realize, of course, that we have not been able to present all these exciting and challenging perspectives. But it's clear to me that each of these findings have found a common, if necessarily polyphonic, voice in assessing the importance of culture to health.
And how a better understanding of culture might help us to make medicine more efficient. There are often two cultures of medicine, if you like. There's the culture of the doctor and what the doctor is trying to achieve, and the culture of the patient. When we become ill, we think and behave in very different ways to the accepted medical model. So the idea is that we can make medicine more and more efficient. We're always searching for the magic bullet. Personalized medicine means that we can tailor the type of medicine and the dose to fit the genetic profile of the patient. So these are huge advances, but they will only be effective if we think broader.
Obviously, these are only snapshots of what is in this, this relatively complex document. And we invite you all rather to actually have a read and come back to us with your own thoughts about it.
There are some thoughts that came to us a few years ago. By the way, the Lancet Commission on Health, being an obstetrician, it's had a very long gestation, and we know what happens with things with long gestation, like elephants. But it's been an incredible and really illuminating work. Some of the things that came to mind was I work in a hospital that is so multiculturally diverse that I think we can find up to 100 different languages spoken by the staff. Not to talk about 160 different languages spoken by the population we serve. And one of the things we used to think about is the outer donut of London, which are the inner city hospitals around the North Circular. Often we find that it's a challenge to raise patient expectations and patient experience. The quality of care in terms of outcomes might be very good. The quality of care in terms of patient safety often is very good, but the quality of care in terms of patient experience has been particularly difficult to raise. And some of the things that come to mind is, why is that? Is it because we're trying to give care in a community where we do not understand their expectations of well-being and acceptance and access to care? When we give aid to third world, when we think about our corporate social responsibility, and when we think about global health, from malaria to Ebola to non-communicable diseases, how do we expect to have the greater output in terms of the input we are putting in terms of health if we don't understand the cultural nuances and the expectations of the people to whom we are giving aid?
I found this a profoundly, very, very powerful report. It wasn't what I was expecting. I must say that my own clinical discipline is general surgery, and I am a traditional surgeon. But I do a lot of research, and I've thought of the Lancet as a place where I can publish our very best clinical trials after rigorous peer review. We were given the opportunity a few days ago to look at an embargoed copy of this report. And reading it, I was struck by a number of issues that I think are very important for the way we take forward the transformation of healthcare in our own country. And of course, as we've heard earlier, understand how best we can make contributions overseas. Let me turn to the overseas contribution. A few days ago, I was in the Gulf in Abu Dhabi, and I was looking at some data coming out of a very large registry, trying to understand how clinicians anticoagulate to prevent stroke. And I was struck by a very peculiar observation, and that is many patients in Abu Dhabi are put on multiple anticoagulants. So warfarin, a new anticoagulant, another new anticoagulant. I thought, this is madness. There is a disastrous breakdown in the way we're collecting data. This is impossible. The reality is the culture there is to go from doctor to doctor in an insurance-funded system and take the advice from each in an additive fashion, rather than dismissing the last guy's advice and taking the new guy's advice. So clearly, as a result of that, there is a polypharmacy to a very dangerous extent. Something that I hadn't appreciated till I read this report, and finally I understood that the culture there of not trusting, I mean, I make an assumption, it's wrong for me to do that, but anyway, the culture is to go from one to the next and assume that they're all additive rather than individual. The culture isn't about somebody else, but actually our own cultural perceptions have a huge impact on the way that we look at those in front of us when we have the privilege to treat them, and indeed how we interact with our organisations, and broadly the hierarchy, which is the establishment of medicine in our country. And there are very solid cultural norms, as they currently exist, that will have to undergo rapid transformation if we are going to be able to deal with what I think is the third issue, and that is society's changing views about medicine, which is a cultural dynamic, but also a dynamic driven by a change in demographics, certainly in our country and in our city.
So what I'd like to do in the time that I have available today is really to reflect on what this report means for us working in public health in England in the 21st century, and to think about some of the key tenets of the report and the importance of culture in helping us to think differently about what we're trying to achieve in health and well-being and in public health today. So a key element of the report from my perspective is the realization that we need to move beyond thinking of culture and health, not only in the individual context, but thinking of health systems, of the political cultures which surround and influence individual behaviors, cultures, and outcomes. A key element of what we now have to do as we think about public health is think about opportunities to change the way in which we're conceptualizing health and the relationship of the population with our healthcare system. A key part of this is looking at the culture, and the culture of how individuals view the NHS and view their own health and well-being within the context of NHS health services. Finally, as we think about ways in which we're not only thinking of inequalities, but also our health improvement programs, Public Health England is interested in thinking about well-being. And I'm delighted to say that only today we launched the first What Works for Wellbeing Centre, which Public Health England has been a developmental partner with in association with a range of academic as well as voluntary and community sector organisations to think about the evidence for well-being and what needs to be done to translate what works into practical actions. Again, arising from this report, as we think about the cultural determinants of well-being, any success in this domain will require us to think about culture and the intersections of culture with well-being as well.
One of the things that Richard did in the Lancet in doing this is to legitimise this discourse amongst medical professionals, amongst doctors, and that is truly important. And I think it's not so much the culture of the people we as doctors or we as health professionals purport to serve, it's the culture of we who do the service. One of the things that I've learned, I think a lot, is that most doctors are not interested in health. Most doctors are fascinated by disease and illness. And most health systems are actually not that interested in health either. I worked for a number of years in China, and one of the things that I was very interested in is the way you fund doctors, healthcare workers, hospitals. The way you fund a system tells you a lot about the values and the culture and what you believe in. And the interesting way that British health workers are funded, or were funded in China, was that every member of the commune paid a small amount to the village health worker while they or their family was well. And when you stop being well, you're allowed to stop paying your village health worker. Now you think about that, and what that does is that highly aligns the incentives for health. Hardly anywhere in the Western world do we do that. We have a system where we monetize illness. What a culture that is. We have a system that pays hospitals, that incentivizes hospitals to suck people in and medicalise health, to medicalise prevention. So one of the things I'd just like to finish is by aligning what the Lancet and what the UCL Commission and the Grand Challenges has done in the first report about climate change and about the fact we are knowingly leading unsustainable lives and engineering unsustainable systems into the absolute essential meaning of culture in doing what I think we're here to do, which is to help people live lives they have reason to value. And if that is not based on the culture, both of those who serve and those who purport to be served, then we are in a sticky situation. So absolutely hats off to Lancet and to UCL for what I think is a groundbreaking report, a groundbreaking commission.
There is another medical journal which is read all over the world, which has a high citation index. It's not as good as the Lancet, but on October the 2nd, they published a paper which was jointly authored by a general practitioner in Camden and a doctor in Boston. And it described the life course of 3 people: the grandmother, the mother, and the grandson, living here in London, and each generation life course was the same as the previous one, just 18 years later. The cost of looking after those 3 individuals in 2012 to 2013 in this country was £1 million. £1 million. So, dealing with health inequalities is not just an ethical imperative, it's an economic necessity. You may not know, but you live in the second most unhealthy nation in the developed world. Which is the most unhealthy? The United States of America, where they spend 17% of a GDP that's larger than ours on healthcare. They do pay surgeons to operate, of course, that's part of the problem. So we've got to deal with this problem. We've got to understand why people live lives which are not the lives they want to live, why they live in these conditions of chronic anxiety and tension and dysfunctionality. They are people like you and me. They deserve a lot better. And it's not an accident that Casser, who wrote the article in this journal, whose name I can't mention, is a general practitioner, because they understand the narrative, the lives of the patients that they serve. So that, I think, is the future. And I'm going to take a copy of this report down to Newham tomorrow. In fact, I'm going to pinch 1 or 2 more on my way out, because we need to engage anew with the culture. And this report is going to be very useful indeed to us.
So it's Halloween this week, and this report, in a very good way, made my mind turn to Wes Craven's postmodern horror masterpiece, Scream. And those of you who've seen it will remember that amazing opening scene with Drew Barrymore on the phone with the killer, and that payoff line, "The call is coming from within the house." And that's the line that this report kept making me think of, because I work in medical humanities and health-related sociology, and a lot of the content of this research, it's not new research. A lot of this has been bubbling around in humanities and social science for a long time, this idea that culture is an important and key part of health and public health. But in the way that Scream is incredibly knowing, there's nothing new in Scream, it's incredibly knowing. This report is incredibly knowing, and I think, to echo what David said, the extraordinary thing about this report is that it is legitimating that humanities and social science work within the world of medicine, and I really appreciate that. The call is coming from within the house in this case, and I think that's extraordinarily exciting. Medicine and science have to recognize that they themselves are also culture, or a set of cultures, and it's only by doing that that we'll be able to move on and tackle some of the challenges rightly identified here. And that's all I have to say. I think it's a great report.
Thank you. Yes, so there's somebody here from the World Health Organization who's going to talk about culture. I'm sure that's going to raise a couple of eyebrows. Like a fish that has found water, it seems that public health has found culture. We're so suffused by culture, so totally steeped in it, that we often forget how powerful a force it can be. And yet it's becoming increasingly clear that cultural interactions, cultural participation, cultural awareness have an important and quantifiable effect on increasing well-being, on prolonging life, and on improving healthcare. The publication of the Commission report is welcome and timely, but it has not come as a surprise. In the last decade, a growing number of initiatives related to medicine and public health have prepared the ground for a re-examination of this very topic. The Lancet itself recently published a planetary health manifesto calling for collective public health action on all levels of society. Governments, intergovernmental organizations, think tanks are highlighting the need to look beyond GDP and towards more equitable and more sustainable targets, like well-being. Well-being is a concept that is culturally constructed. In fact, the very term itself often represents a linguistic challenge for translations into various cultural contexts. Words such as Wohlbefinden in German, Благополучие in Russian, or bien-être in French are either artificial constructions or at least subtly different in resonance from the English concept, and of course from each other. To help us think through some of the inevitable challenges, particularly with respect to well-being measurement, the WHO Regional Office for Europe has launched a cross-cutting project on the cultural determinants of health. Through a multidisciplinary expert group that will meet for the first time in early 2015, this project is looking to engage more seriously with much of the important work on culture and health that is being conducted in medical anthropology and the wider health-related social sciences. Inevitably, we will be confronted by the problem of defining culture. In fact, the report points out that we need a better definition of culture. But as the Commission report says, a quintessentially dynamic concept such as culture cannot be fully known by simple recourse to existing formulas or normative paradigms. Curiosity is key here to innovation. What we need, it would seem, is not a single definition of culture. Instead, we need to encourage the creation of many definitions of culture, born out of meaningful, personal, and local contexts. And for this, we will be looking towards some of the most promising and innovative work from the medical humanities to help us and our member states understand the complexities and contradictions of culture in its various settings.
So it's my great pleasure to thank David Napier, Richard Horton, the speakers, the panellists for a most stimulating evening, and thank you all for your contribution.